Okay.
Good morning, everyone, and welcome to the final seminar in the Clinical Trials and Evidence Synthesis Seminar Series for this academic year. And we're very pleased to have Dr. Hanan Aboumatar today to talk with us. She is a family practice physician who studied at the American University of Beirut to get a degree in chemistry and also in medicine, and then came to Johns Hopkins University to study health management and received an MPH. And then she did a residency in family medicine at the University Hospitals of Cleveland. And fortunately for us, then she returned to Johns Hopkins, where she is now an associate professor of medicine and public health. Her career and research has focused on patient-centered care and patient-provided communication and family engagement. She's done some work with the patients with COPD. She's also the director for the Center and Patient-Centered Innovation at Johns Hopkins Armstrong Institute. And she's also an associate director for population health at the Johns Hopkins Community Research Network. She's very experienced in working with patients and partners to develop educational materials and to even materials that were developed to train residents on how to share information and the caring aspects of patient-centered communications. Recently, this year, she received a PCORI Engagement Award to build partnerships with patients affected by COVID-19 and their caregivers to better understand their perspective in the recent care experiences to help inform healthcare for COVID-19. I'm really pleased that she agreed to come and speak with us today, and I think it sort of matches this career in open communications that I think she's going to share with us what she might not call a highlight of her career, but in the sense that we all are a learning society and peers, and peer review is such an important part of our field. We really appreciate Hanan coming today and telling us about her experiences leading a trial that there were some problems I identified. So I will leave it to Hanan to tell you the details. But thank you very much for coming this morning.
Thank you, Janet, very much for this nice introduction. And thank you, everybody who joined us this morning. And I will be talking this morning about a study that we had conducted between 2015 and 2018, and in which we uncovered an unintentional error that had major consequences on our data analysis and interpretation of study findings. And so I want to share some of what we learned through all of that experience and a broader perspective about possibilities for reducing unintentional errors in research. So to start with, I have no conflicts of interest to disclose. The study I'm going to be talking to you about was funded by PCORI. And what I'm thinking we could do is start off with a quick overview of the study and then tell you in more details more about the error detection and how we reported it and how we ended up reanalyzing the study and what we learned along the way. We had to retract the major publication, the main publication for the trial and replace it. And we learned some things about error and our vulnerability to error in the research process. I had planned it so that we would have plenty of time for discussion at the end, and I hope that we will have some conversation around this topic. So to start our conversation today, I wanted to have a sense of the group's experience with errors. And so thank you so much, Taylor, for setting up this poll for us. I'll give you some time to respond.
I'm not sure why, but I am unable to vote, but I would be voting yes.
Okay. So about 3/4 of us, and a little bit more since Janet has voted yes, say that they have detected an error close to presenting an analysis or publishing a paper. For the other quarter, I say maybe you haven't done this work maybe long enough, but it is very likely that somewhere down the path you might be encountering errors close to presentations or publications. Taylor, you want to move to the second poll question?
This is a similar question. Have you ever reported an error in a paper that you have already published or submitted for publication?
And I think I may be a co-host, but I'm going to say yes again, just to add.
Okay. So for the question about ever reporting an error in a paper that you have published or have submitted for publication, we have 50-50 answers. And that's actually good. I was wondering what this group's results may look like. And we know that usually in general errors are underreported, but there has, and for multiple reasons, but there has been a lot of calls among editors to encourage people to report errors and for those errors to be, provided for the readers so that they may learn from the process and to maintain this correcting feature, the self-correcting feature of science. Okay, thank you very much, Taylor. I'm just gonna go back to the presentation so I can tell you a little bit about the study that we had done. So it's called the BREATHE study, and BREATHE stands for Better Respiratory Education and Treatment, helps empower. And the goal of that study was to develop and evaluate a comprehensive patient and family-centered transitional care intervention to improve outcomes of hospitalized patients with COPD. So for those of you who are not in a clinical space, COPD stands for chronic obstructive pulmonary disease and what many people, for example, refer to as emphysema or chronic bronchitis. And it is a condition that causes irreversible damage to the lungs and leads to these flare-ups that may land people in the hospital and the emergency room. COPD has major bearing on quality of life of individuals. So because they can't, it reduces their ability to do activities and it has a major impact on their overall health. And what transitional care intervention means is that we were trying to help people who have been hospitalized due to a flare-up of COPD as they transition from the hospital to the home and get them into better shape in the long term. I'm not going to dwell on the actual program for the purposes of this a presentation. I just want to tell you that what we were providing was to connect each patient with a COPD nurse guide who basically supports them in the hospital and up to 3 months post-discharge. That person provided individualized education and support for the participant and really focusing on COPD self-management, what people need to learn about managing this chronic condition in terms of managing, for example, their medications, detecting early signs of flare-ups, and what to do about those. In general, recommending active lifestyle and stopping smoking and connecting people to the existing services in the community that can help them succeed and basically cope with this chronic condition. The goal of the study was really to improve people's quality of life and reduce their need to go to the hospital and the emergency room. And part of that study was giving them an action plan by which they, for certain type of symptoms, they want to have early contact with their providers so that treatment for the flare-up can be initiated early and does not develop into a full-blown flare-up that lands them in the hospital. This was a randomized controlled trial of 240 people. The comparison group was usual care. The intervention group included a 3 months period, as I said, with the COPD nurse working with the patients. We collected data periodically during the study, but our main outcomes were at 6 months after they left the hospital. And we collected that outcome through medical records review and interviews with the patient. So the primary outcomes of the study, we had co-primary outcomes. The first outcome was the number of COPD-related acute care events, and that is a combination of hospitalizations and emergency visits per participant at the 6 months time point. And the second outcome was a change in the participants' health-related quality of life as measured by a validated instrument called the St. George Respiratory Questionnaire. And we basically measuring that change post-discharge at 6 months post-discharge from their baseline. The St. George Respiratory Questionnaire measures quality of life on a scale from 0 to 100, with 0 being the best quality of life, 100 being the worst quality of life. And 4 points difference on St. George Respiratory Questionnaire is considered clinically meaningful. Okay, so we conducted the trial and then we published the findings in JAMA. And that was back in 2018. And our results were that at 6 months post-discharge, the intervention participants had fewer COPD-related acute care events, almost double, 0.72 versus 1.4 per participant. And a better change in St. George Respiratory Questionnaire scores at 6 months, negative 1.53 for the intervention versus plus 5.44 for the comparison group. We had many authors on this paper, and we had many partners on this work with us. And I don't know if Dr. Wise is with us. He has been a mentor for me along this whole process, and an amazing mentor for that purpose. So about a year after we published the study, we detected an error in our data analysis. So I'm going to give you quickly a brief background on the structure of the study, and then we'll talk about the error. So the data analysis was conducted in 2017-2018 at the Johns Hopkins Biostat Center by a senior biostatistician and a data analyst. The database of the study we used is REDCap, and the data analyst used downloads. I'm sorry. I just want to be able to see all my slide. Yeah. The data analyst used downloads of the raw data from REDCap that were shared on a secure JHBox drive. And the purpose was to prepare separate analytic data sets for the various measures. Now, we prepared an analysis archive in which all the analytic data sets and outputs were kept at the close of the study for future reference and research. And our senior biostatistician was close to retirement then, so we had a new analytic team on board that started to familiarize themselves with the study archive in preparation for continued analysis. And during the review of this archive, the new data analyst discovered a coding error in a data prep do file that actually flipped the variable referring to the study arm assignment. So what was the error specifically? In the data prep do file, a new variable arm was generated to recode an existing variable that says randomization assignment in the REDCap database. The purpose was to change the randomization assignment variable format of 1, 2 to a binary format of 0, 1. Now in REDCap, the randomization, in the REDCap codebook, the randomization assignment is 1 equals intervention, 2 equals control. And so, however, the data prep do file code stated generate arm randomization assignment, recode arm, where 1 equals 0, 2 equals 1, and then defined the arm as 0 being the control and 1 being the intervention. So what that meant is that we flipped the arms in this study. And for all intensive purposes afterwards, every time we were looking at data for intervention, it was indeed the control. And every time we looked at data for control, it was indeed the intervention. Now, this was in a data prep do file, hidden somewhere. This was a very hidden type of error that was not easily discoverable. So in March, we discovered this error and we reported a potential data error to IRB and JAMA editor. We wanted to confirm that this actual programming error in the do file did actually affect the analytic data sets. Because the person who had written that do file had left the institution in the interim, and the senior biostatistician had continued to work on the analytic data sets. And so on April 9, we actually confirmed that the programming error did indeed affect the analytic data sets. And we initiated a grounds up reanalysis. The idea was to reanalyze the whole study to detect any other errors. And this included everything from starting from data review, repeating all the data preparation and programming process, and then full reanalysis. And for added confidence, we had 2 biostatisticians performing double programming and an independent analysis of the study primary outcomes. As we did the reanalysis, we identified 3 other errors. That one of those errors actually did have an impact on interpretation of study findings. And that error has to do with imputation of the St. George Respiratory Questionnaire scores. So per our pre-specified statistical analysis plan, we wanted to impute the worst possible St. George respiratory score, which is 100 for the participants who had died, meaning they have they're not alive, so therefore they have the worst possible quality of life, if you think about it, so we don't have a lot of missing bias due to the deaths in the study. However, if you participants had a missing St. George respiratory score at 6 months, but they actually died after that time point of 6 months, but by error, a value of 100 was incorrectly imputed for those missing scores instead of leaving it as missing. And so when we corrected this error so that people who were missing, who were alive at 6 months and missing stayed as missing, the significant difference in health-related quality of life between the study groups was no longer present. Now, there were 2 other minor errors that we also identified through this reanalysis. One of them occurred with summarizing the baseline medication classes that participants were using, and that's affected the patient characteristics table. And another was a missing count of 2 hospitalizations among the participants, a total of 2 hospitalizations in the whole study. Okay, so when we confirmed that these errors have happened, and we then went back to the JAMA editor whom we've alerted a month earlier, saying we did indeed find a major programming error that altered the findings of the study. And then what the JAMA editor responded was, when programming errors occur, altering the findings of a study, we have a protocol for approaching this issue. And they sent us their guidance as to what should happen next. And what they suggested we do is provide a complete explanation of how the errors were discovered, a review of the article, data, and analysis to see if there are any other errors, which we would have already done, and then complete itemization of the corrections that needed to be made, and basically to provide them with a track changes version of the actual published article with the corrections, and that also involves any changes to the figures and to the supplement, and detailed explanation of those. And a statement about how this affected the study, whether it affected it in a qualitative manner, meaning changing the whole findings. So we provided all of those, including an added analysis where we try to understand what's going on, because obviously the new reanalysis finding showed paradoxical effect where we had twice the number of COPD related events in the intervention compared to the usual care arm. And so we submitted those, and then JAMA responded to our submission. And I just kind of copied this from my email saying we met yesterday and have decided that the article must be retracted given the major coding error, reversal in findings, and additional analysis. And so all of those contributed to this decision. That said, we are quite interested in publishing a new article similar to the one you submitted, which we had provided, but with some additional limitations. And their major limitations that they suggested is that the additional analysis that we have done to better understand what happened in this study would be labeled as exploratory analysis. An editor's note will accompany that retraction explaining our decision, and we will require a complete explanation from you that will also be published, and that basically was our retraction letter. One thing that Dr. Bushner sent to me and Bob at the time with that decision, JAMA decision, he included something that Bob suggested I share with you, as it reflects the importance of the role of editors in this and the scientific in maintaining an accurate scientific record and integrity in the science. He said this might be an odd comment, but I want to thank you for the professional manner in which you have dealt with this issue and with us. Sadly, I have a daily diet of undeclared conflicts of interest, fabrication of data, unprofessional behavior, and angry authors and readers. It comes with the territory, but I always feel energized and renewed when I deal with authors who are professional, responsive, timely, and recognize the complexity of reporting scientific results. JAMA has the responsibility to ensure that the scientific record is accurate. The position that JAMA had on this is actually in line and consistent with what they've been doing all along. 2 years earlier, they had an editorial published called Correcting the Medical Literature: To Err is a Human, to Correct Divine. And there they talked about this approach of retracting and replacing papers that have major errors. And they suggested that articles with pervasive errors that cannot be managed with a simple correction notice and letter of explanation might be best managed with a retraction and replacement of the published article. For example, a pervasive error could result from a coding, during a coding error during data collection, or a miscalculation that caused extensive inaccuracies throughout an article. Publication of pervasive errors that, when corrected, show a major change in the direction or significance of the originally published results, interpretations, and conclusions is a serious matter. However, if the errors were inadvertent and the underlying science is still considered reliable and important after subsequent review, the original article can be retracted and replaced. This can be done with a letter of explanation from the authors that is published, with the retracted and replaced article, and an online supplement that contains a copy of the original article with the errors highlighted, and a copy of the replaced article with the corrections highlighted. Such replacement removes the stigma associated with serious but honest errors and allows readers to access and use the work in its replaced version without being stopped by a do not use retraction notice. The Lancet has also used this policy, and the International Committee of Medical Journal Editors adopted a policy in support of this option in 2017. So that's what we did. We published a retraction notice, and in which we detailed the reanalysis process, as well as the findings and the impact of the findings on new findings on our interpretation of the study. The new paper was published in 2019, almost a little bit more than a year after the first paper. And the results there was, for the COPD-related acute care visits, it was a complete, like an exact reversal of the earlier findings, because all what happened is we reversed the arms. So, for the St. George Respiratory Questionnaire, there was no significant change at 6 months. And the additional analysis revealed that the increase in acute care visits in the intervention group was basically, well, the significant really increase in acute care visits in the intervention group was limited to those patients with high activation status at baseline. With that high activation status reflects the level to which patients are quite proactive in managing their healthcare. And so those are people, and those about half of the people in the study were particularly primed for an intervention like ours, where it's about self-management and making sure you stay well and detecting signs early of any flare-ups. And so those people reacted to the intervention, um, uh, were actually quite responsive to the intervention. But the consequences of that was that we had a paradoxical findings where people, um, instead of contacting their providers and then having early treatment for flare-ups, we think what happened is that perhaps they chose the path of going to the emergency room or try to reach out for their providers, but then the process may have been too complicated or took time. And with COPD being an anxiety-provoking situation, as you cannot breathe when you have a flare-up, they decided we're going to go to the emergency room. If interest is that this was way more common among men than women, about 4-fold more among men than women, and that is a finding. As I said, it was exploratory finding. This was not pre-specified analysis, but I think it's something that is very much worth of additional inquiry. Okay, so I want to shift gear to speak about some of the error consequences. And I want to acknowledge that Nakeeb is with us on this presentation. He was the project manager. And Emmanuel Garcia is also with us, and he was the data analyst who helped uncover this error in the study. All right, so what were some of the error consequences? I'm going to say about some of the direct consequences of this error. Obviously, the reported results and interpretation of our study findings that we did in 2018 was incorrect. And I've been to many conferences where I presented this information, so I feel like, what was I presenting? Obviously, we had to retract and replace the JAMA paper. And we had to, for those of you who worked with PCORI, you know what I mean. We had a final grant report that was extensive, that has been approved, and we had to correct everything and resubmit. We also have to retract another paper that was close to publication that was doing reporting additional analysis based on the BREATHE study. And we retracted 4 grant proposals that were written based on the BREATHE study findings. And some of those were close to being funded. So we had a lot of work involved in kind of mitigating the effects of this error. In that process, we learned a lot about the research process in terms of how vulnerable it is to errors. And so a group of us decided to come together and think a little bit more about this problem. And then we wrote a perspective piece that is currently under peer review. And you see the co-authors here. Carol and Emmanuel are in the School of Public Health. Aishi is at Armstrong Institute. She's a human factors engineer. Nakeeb was a project manager for the BREATHE study, and Jamia and Samuel were the main coordinators of the study, and Dr. Weiss, who has been my mentor along the way. So what's our perspective? Our perspective is that the research process is very complex and therefore prone to errors. And I'm sure anybody who's doing work in research and as evidenced by this poll would agree with us. Now, there has been error reduction strategies that have been used with success in multiple fields, such as manufacturing, nuclear power, aviation industry, and more recently in healthcare. And those could be applied to research as well. So the concept here is moving from just telling people providing more courses to people and telling them how important it is to maintain an accurate scientific record and talking about research integrity, is to build on that and take it to another level where you're having more of a system level approach to error reduction in research. The goal here would be to reduce the likelihood of error occurrence as much as possible and maximize the chances of detecting those errors and addressing them and correcting them way before they result in negative consequences. In the next 3 slides, I'm going to share some examples of what we mean by that. Based on a lot of work in high-risk industries, there have been a realization that errors do happen, and we're all humans and we run complicated processes. So the processes in general are vulnerable to errors. And so what we really want is to think about the process and the whole system and make it less likely that errors could occur. And that is obviously the highest level, the most effective ways to prevent errors from happening in the first place. The second level is to detect errors when they happen very early in the process. And then the third level would be mitigating the errors that we recognize have happened and learning from them. And so what I'm going to share with you is some examples of these strategies that have been well tested in other industries, and giving an example of how they have been also recently applied in healthcare, and then also an example of how can be applied in research work. And again, this is part of the paper that I had mentioned is under peer review. So for preventing errors, there are multiple strategies. First is to establish a reliable process, meaning that you have a standardization whenever it's possible. If you repeat the process, you get the same results, right? And so example in healthcare is that when checklists were introduced for inserting central lines, such as, for example, how to clean the site, where to put the line, how to maintain a sterile field, etc., there was a significant prevention of catheter-related bloodstream infection, and those are very serious types of infections. In parallel to that, maybe in research, is to create a data management plan detailed where data elements that details how data elements will be handled. For example, a description of how missing values will be exported and coded, distinguishing the handling of zero values, and specifying out of range and impossible values. So what we mean by that is that is laid out and specified and followed across a range of different research projects. And this is it's more of a standard approach, not everybody having a different process. Another way to prevent errors is to change the process or devices, for example, in healthcare, so that it is impossible to make the error anymore. And this is really for things that lend themselves to this solution is the best solution ever. And so for examples in healthcare, we have redesigned certain machines so that fatal accidents would not happen. It's not possible to make that accident anymore. Think about it like the money machine. You put your card in, all times the money machine would take in the card and then you forget about it, right, in the machine and leave. And many of the newer machines, that cannot happen because you cannot put the money in the machine, you just scan it. There's no place for it to go in. So that's an example of changing the whole process, so an error is not possible. An example of that in research is using softwares that allow direct export of tables from statistical analysis, right? Instead of copying, pasting values from long analytic outputs where you may, by error, copy the wrong thing or end up pasting it in the wrong place. So this is a good example of a way by which you made the error impossible to happen. Eliminating unneeded tasks or parts. That's another way to prevent errors. If it's something you don't have to do, don't do it. A good example is what happened in our trial. We didn't have to necessarily recode the variables. There could have been a plan from the beginning that reduced any need to relabel. And depending on the softwares, I know some softwares require this. An example in healthcare is we had some solutions that were quite concentrated. So when people by error did not do the dilution before giving the patient the medication, they could kill them. And those were available in the market, and accidents did happen like that. And so now, for example, for this solution, esmolol, which is used for cardiac arrhythmias, it's not available anymore in concentrated format. And it's like now available and ready to use 10 milligrams per milliliter vials, so no dilution is needed. Now, by eliminating that part of the process, which is dilution, you have practically eliminated the errors that can happen in that part. And that applies to the recoding. By eliminating unnecessary recoding, you eliminate the chances of an error happening in that part. A couple other additional strategies for preventing errors. Facilitating the work so that you reduce the complexity and it makes it less likely to make mistakes when the process is clear, right? In medicine, there are examples, for example, in medications where we use different ways of writing, different fonts of writing, so people cannot quickly mix medication. For example, nurses on the units may mix hydralazine and hydroxyzine. And so this way you notice how the middle letters are written in capital format here. And that is so that it attracts the eye that this is a different medicine. This is a medicine that can lower your blood pressure quite a bit. So, and you definitely don't want to give it instead of hydroxyzine. Now, an example of facilitating the work is to creating a process by which data analysts can become very familiar with the research study, background, design, and all the input forms and instruments before proceeding to data preparation and analysis. And now, I mean, this can be quite complicated in the current research environment, and thinking about how that could be accomplished would prevent many errors. And then finally, but really extremely important, is to create a work environment that strives to prevent errors and support teamwork. This cannot be overstated, because if you have that environment, it allows people to openly speak about errors and then learn from each other. And thinking, and that allows also for thinking about how the work is orchestrated between the various team members, given the complexity of the research process. And in healthcare, for example, handoffs is a huge deal, and there has been a lot of effort to try to make people work together as a team to prevent errors from happening. In research, we often have handoffs of information and responsibility between team members. For example, when somebody leaves and someone else takes over, and every time handoffs happen, one has to think of them as high-risk, error-prone periods, because things may be dropped, miscommunications may happen, misinterpretation of what someone else has done may happen. And so ensuring sufficient communication and clarity is really important. Now, the second level, when you can't prevent errors, and we know we cannot prevent all errors, some errors would still happen, one would want to make the process so that it is easy to detect errors. There are a couple of strategies I want to share for detecting errors. The first one is to making the errors more visible and discoverable. So making it easy to figure out when an error has happened, to see them, so you don't have these hidden errors, which is really dangerous. An example in healthcare is the ID bands that people have to put on their hands before they come into the hospital. In research, using variable names that refer to specific forms is helpful, because then you can easily go back to the source document and make sure that errors, you can detect errors easily. And then the second one is to create redundancy, meaning multiple checks. In healthcare, for example, before we give someone a chemotherapy medication, we double check the dose, because that the consequences may be really big if we were to have an error in delivery of a chemotherapy medication. It can easily overdose and kill a person or have major consequences. Think about that, like in terms of research, there are some critical parts of the research. For example, analysis of the primary outcome, right? And I know it is a practice by many researchers to have independent analysis of study by primary outcome by 2 biostatisticians as a means to create that redundancy, a multiple check. And finally, mitigating the effect of errors. So when errors do happen and we don't detect them and they end up leading to these negative consequences, like what happened in our trial, what you want to do is minimize the direct effects of the errors. What does that mean? You want to kind of reduce the negative impacts. For example, by reporting the correction on all published work is really important, so that you correct the science that is out there. Another very important thing about reducing the effects of errors is learning from those errors so we can prevent future events from happening. And really, the best way to learn from the events, first one, you cannot learn from events if people don't know about it. So the first thing is to promote a culture that encourages discussion of errors and discussion of underlying causes so that you could learn from them. In healthcare, we do have error reporting systems now that allow compile these errors and allow for analysis of what's happening and therefore coming up with prevention strategies. And so that ends my slides, and I just put in this picture because I like it. It just reflects, that we're all in this together in science, and our boat is never safe in some ways unless we work together. So thank you for listening, and please go ahead and ask any questions you might like.
Well, thank you. That was an interesting presentation, and I really appreciate you willing to talk about it. I imagine as this was evolving, that you probably felt sick to your stomach several times. One thing I have to ask, though, and I don't mean this in a critical way, but sometimes what may kind of alert you that something isn't quite right is that data don't hang together well. Mm-hmm. So I wondered, was part of the initial analysis at all to look at whether people who attended more sessions had a better effect, or any kind of counting of their interactions that might have given a clue that something was amiss?
Yeah. So this is a great question, and I see somebody in the chat sent a similar question about the DSMB, whether the trial had a DSMB that met regularly from beginning of the trial, and how the treatment assignment was handled in the DSMB. And so thank you both for your question. And the answer to your question, Janet, is no, only because the events that we are tracking are so common, that happen so commonly, whether that be ED and hospital visits. They happen so common. We're not dealing with rare events here. And so to really capture this, we had to do interim analysis. And we did have a DSMB in the study that met from the beginning. And early on in the study, before we started the trial, the DSMB met and agreed that we will not conduct interim analysis in this study, which was a 3-year period in which basically the recruitment and intervention is happening over a 15-month period. So it's a brief period, small study with a low-risk intervention where we're not giving any medications or doing any procedures to people. And so the decision was that, and it's a small study, as I said, that the interim analysis may actually be more misleading than helpful. that there was no reason to conduct an interim analysis in the middle. We did not have stopping rules for the trial for that matter. So then that reduces the value of the interim analysis as well. So so that was the decision of the DSMB. And so we didn't have an interim analysis. And then to answer Barbara's question, the way we shared the data with the DSMB was masked. So treatment assignment was not made known to them. And that was again by, that was something that the DSMB was, we had agreed on with the DSMB from the beginning. So we were seeing these treatment arms, and so and when you see events happen, more difference between the arms, that's what you really want in the in the trial, right? So that signal wasn't there.
So I have a couple quick questions. One of the problems with the interpretation of these data is that the original erroneous analysis confirmed your hypothesis, and therefore it was quite pleasant to accept, making it easier to not look deeper for the error. The very first trial I chaired, we had an unexpected mortality difference. It was an AIDS trial. And I remember the director of the coordinating center, Kurt Miner, getting two statisticians to independently calculate the results without talking to each other to make sure it was real, because nobody quite believed it. Yeah. You suggested that as one of the possible ways to deal with this problem, but was that done in this trial?
Yep. So thanks for your question. And that's interesting. I mentioned that we had to also submit a final report to PCORI, and then this paper was submitted to JAMA. And every time we submitted this, like so for PCORI, they asked for a multiple sensitivity analyses to look at the data in different ways. JAMA asked for a complete, look at, and created these box plots so that you could see the actual data for each point. And so for each participant. And so there was a lot of rigorous review to verify and do sensitivity analysis and to make sure what we're seeing is real. And we did all of those, and obviously all of those confirmed the findings, right? Because you have a real finding. The only thing is that because we were not seeing that coding, that programming error in how the arms were coded, none of that was helpful in this case. We just confirmed that, yes, there is a big difference between the arms, but we did not know that the arms were reversed. Now, the things that we did not do in this initial analysis, but we ended up redoing, was an independent programming for the primary outcome.
Yeah. So
if we had an independent two people independently program and do the analysis, we would have hopefully, not both of them would have recoded the arm assignment and or made that error.
Yeah, and I think that's a good point. And we do try to do that with our primary analysis, and at least that's our standard operating procedures. But it gets very, no one has the resources to do everything twice. It would be great if we did. But I can, it's, the whole sequence seems very, a pitfall that many of us could fall in. And even that 1-2 coding with, that's how we code yes, no. And if you if you recode it the wrong way, you get absolutely the wrong answer, but doesn't quite as much impact as when that 1-2 is indeed the treatment assignments. I wondered also if you could comment on the more recent practice of, I'm not sure if preprints is the right word for it, but we saw a lot of publication of results from trials and studies about COVID-19 that hadn't undergone any peer review in the attempt to get information out in an emergency situation quickly. Do you have any thoughts on the wisdom of that policy?
I think, there's so many things that we're doing in this pandemic. I think the least of them is the preprints that one could talk about. And it's always, we're kind of like learning as we go. This is the first pandemic we have where we have such big access to online information globally, and knowing that this pandemic started in different places of the world at different times, there's a huge value in having information out there to stimulate the scientific conversation. I think personally that is not bad. The only problem is like in terms of scientists, the learning, seeing some thoughts, but one has to think about them like you take this with a big, you have to be doubtful about everything you're reading out there till it's been verified. The biggest caveat is not to have clinicians rely on these information when it has not been verified yet. And unfortunately, with the pandemic, many times, particularly for patients who have been very sick, clinicians had relied on information that's not like necessarily, correct. And we are learning as we go. But I think the intent is great. And I think the more sharing we have and expediting the process, I think expediting the process is good, but you have to have like big, almost like a good guidance for people as to the limitations of relying on information from these preprints, as long as you are using this information to generate new ideas, new ways, new questions, and help advance the science in a faster pace. Because what this pandemic also taught us is that, science is like, we need to keep up so fast. We have to move so fast, and thankfully we have. And the biggest example of that, in my mind, is the vaccinations being out there already. And that's something that I think also, scientists should be proud about.
Well, thank you. And I think you should be proud of your work. And I really, we're about learning about clinical trials, and we often learn more by our mistakes than our successes. I see a hand up. Is someone, Naquib? Do you want to say something? Or maybe, anyway, I really appreciate your willingness to come and share your experience with us, and look forward to hearing more from you in the future. It was a very interesting presentation. And so thank you very much.
Yeah, thank you for being with us this morning. I'll end the recording here.